Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Hi, everybody. Welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
Today, we're going to be talking a bit more about neoadjuvant and in particular anti-PD-1 blockade. And we're going to be focusing on a paper from Nature Medicine 2019, Huang et al. But maybe before we start, Sapna, I can ask you a quick fire question, which is, do you make your bed in the morning?
There's some background the reason I like this question, but the short answer is yes, but I have a really simple, I just have a quilt on the bed, a sheet and a quilt. So it's more straightening. I don't do any tucking, just make sure it's straight. And I like to, but not for the reasons that General McChrystal gave in this very famous University of Texas commencement speech. Do you know what I'm talking about? Have you heard of this one?
No, which is what?
So General McChrystal, one of our top ranking generals for the U.S. Military, gave a commencement speech at the University of Texas at Austin. I can figure out when it was. But he starts out by basically saying, make your bed. Make your bed. And this is one of the first things we teach military recruits. They are, the first thing of the day is basically, can they make a square bed, basically? The reason is it's like a small bit. The rest of their day is so unpredictable. The rest of their day when they're combat ready could be filled with, dangerous missions. It could be filled with hopefully, practice and all these things. So they may not get another victory that day. And so making your bed is the small victory to start off your day correctly. And if at the end of the day you have to reflect, you can at least say, well, at least I made my bed. So I think that's the gist of it. That's not the reason I make my bed. Certainly, even though my days are unpredictable, I don't do it for a small victory. I just think it looks nicer and it's nice to get in at night when it's made.
Yeah, that reminds me, actually, I was watching a program once about, I think it was Marine Commando recruits or something like that, doing training. So they're all quite young. And what surprised me about it was they actually instructed them how to wash. I kid you not, they actually went in the showers and they showed them how to wash. Particularly, I think, body parts that, need, let's say, particular attention when you're kind of out in the field. But I was a bit surprised they were showing kind of grown people how to wash. Anyway, let's move on. Unless you've got a response to that.
Of course I do. You don't have to wash like your shins. You probably don't need to wash your forearms, but you need to wash your pits, tits, bits, your holes and your soles. Right?
Yeah, that's a nice way of remembering it, just in case you forget what's important. Anyway, we should do some work.
Yes.
So listen, this Huang paper, why don't you take us through it? And I guess particularly, it's a few years ago now, isn't it? Tell us why you think it's nice and important and we should be discussing it.
Right. So this article title, Single Dose of Neoadjuvant PD-1 Blockade Predicts Clinical Outcomes in Resectable Melanoma. And like you were saying, Alexander Huang is the first author and Thara Mitchell is the senior. I think the title of the article says why it's important. It's a single dose of preoperative PD-1 basically was starting to predict outcomes in the sense that responders, non-responders were having different sort of long-term benefit, or in this case, you could say short-term, OS look. But this was a single center study done at the University of Pennsylvania where they treated patients with a single dose of preoperative resectable melanoma patients with a single dose of preoperative pembrolizumab, and then took them to surgery about 3 weeks later. So this was 27 patients. They then went really deep on the correlative analysis, meaning they looked at the pathology at a very methodical way. They found a 30% major pathologic response. So 5 of these 27 patients had complete pathologic response, no viable tumor in the tumor bed that the pathologist could tell was the tumor bed. I say it like that for a reason. And then 3 of 27 with a major pathologic response, so only 10% viable tumor left in the tumor bed. And then they looked at things like disease-free survival, in patients who had viable tumor, and then those who had more than 10% viable tumor, those who had brisk TIL and non-brisk TIL. They did a bunch of blood work. So they have some beautiful flow cytometry of, changes in the bloodstream of lymphocytes populations just 3 weeks after a single dose of neoadjuvant. That's certainly one of many reasons why this was published in such a great journal, Nature Medicine, just the depth of the correlatives. But, the real take home is they gave a dose. They didn't lose resectability on patients. They found that they could actually induce complete response with a single dose of neoadjuvant PD-1 in a small percentage of patients, but a meaningful percentage. So then this opens the field to say, what about other regimens? What about other durations of anti-PD-1 therapy? The gap, as you've heard me say before, I think that we have with neoadjuvant PD-1 is, what did we do with receptor occupancy with this one dose? If we're able to get complete and major pathologic response in 30% of patients after one dose, what are additional doses actually doing? Are they blocking the receptor better? Are they adding to toxicity? What are we exactly doing? And we haven't necessarily sorted that out to my satisfaction. That's where we're at.
And this was 2019. So I guess a broader question, I mean, you obviously, you're an expert in this field, in this area, might be, what's the context then, if you can say, in 2019, for what other people were doing around the world? And then I guess, how was this built on for where we are today, 2024, do you think?
Yeah, good question. So I'm just checking myself here. Yeah, wrong paper. So the Opacin trial had come out by then. We had some publications in Nature Medicine in 2018 that really spoke to these pilot studies of neoadjuvant versus adjuvant, and you get an enrichment of the T cell expansion in the blood in patients who receive their immunotherapy regimen preoperative. So the field was starting to say, yeah, we can do this safely, though we have some biologic rationale. And now it was getting to the point of, different groups around the world saying, well, what regimens do we like? So here was UPenn saying, let's just do a single dose of PD-1, safe. We won't lose any ground. We are not likely to cause toxicity, which, by the way, also is probably important to mention. No grade 3 for immune-related adverse events with this single dose of neoadjuvant. And then, the MD Anderson group was looking at, okay, what if we did single agent PD-1, and what if we looked at combination Nivo-Ipi? Are we getting to the same A, resectability, B, pathologic outcomes, C, long-term benefit, and then ultimate D, with what difference in toxicity? So around the world at the time in 2019, I think regimens were starting to be explored. And we had already developed the SWOG S1801 study by then. By the time this paper was published in February of 2019, I believe it was, the SWOG 1801 study was open by then, just open. It had been developed in 2018. It had been conceptualized in 2017. And we had just been open in 2019. So, while we may have known about this a single dose, I can't say that we were aware of the details at the time we were designing the SWOG S1801 study.
Yeah, so another question from me, maybe, that I don't think we've talked about before. I mean, clearly in S1801 randomized trial, there's major benefit for this strategy, broadly speaking. I'm just kind of thinking about the patients who don't get benefit from this strategy because, they have the treatment and then, they go down the line. Do you think we're anywhere near at the moment being able to, let's say, do a core biopsy or something like that on this kind of group of patients who've got palpable disease, and then try to use something in that core biopsy to pick a regimen that we think is going to be, give the maximum chance of benefit in that patient? Or do you think that's still years in the future?
There are groups that are looking at that. Certainly, Christian's group has looked at the pre-neoadjuvant specimen for a signature. Maybe more powerful is he then also does an on treatment, on neoadjuvant therapy and looks there. And so there will be a group of patients who are, say, interferon gamma low before you start any treatment, who remain low after you apply, say, single agent anti-PD-1 therapy. And that might be a signal that you need to get them to more of an interferon gamma high signature. So maybe change. There will be a group of patients who are low before you start therapy, who after initiation of whatever therapy will turn into interferon gamma high on treatment. And those are usually patients who, you're probably on the right track. And then an interferon gamma high group at baseline, where perhaps single agent PD-1 is perfectly good and enough. And then they typically remain interferon high. I don't know that he's identified any real major groups that are high before therapy starts that turn into interferon gamma low. So fortunately, we don't really have that group happening. I think you can do that. My hesitation is that core biopsies of melanoma tumors, and maybe any tumor, is a little bit like sampling a pie and getting, your core from the pie and then guessing the filling of the entire pie. And you could be right based on that. You could be wrong. You could get all crust and then you have no idea. You could get a little, hint of red and say, oh, this is strawberry cherry pie, but it's rhubarb pie. And you also could have a pie that is half and half, right? Half of it's blueberry, half of it's cherry. And so I'm speaking to tumor heterogeneity, of course, and that's the danger of any sort of sample, is that you just are subjected to what you have in that sample. Full surgical excisions are more valuable. And then maybe this is where some circulating marker, but we could make the same argument about circulating markers. It's subject to that, moment in time of what's being released that could be different an hour a day from there. So.
Yeah, no, I mean, I think those are all great points. And I mean, we've struggled, I think, in kidney cancer, actually, in particular, with heterogeneity a lot over the years. And, the problem there, just to briefly talk about that, is that a lot of these primary kidney cancers are enormous. And you do one biopsy and it, really, which is one of the things that got us interested, I think, in this whole area in the first place. So I think it's an important point. And then at the end of the day, all of these other things, circulating markers, doing one biopsy, they're going to be some sort of surrogate. How can it not be some sort of surrogate? And that's okay as well. But then the question is, what's the correlation? Have you tested it? Because it's all very well having been able to measure something, but actually what does it mean is the big question. So I've got another philosophical question as well, I suppose, or a bigger picture question about neoadjuvant in melanoma. To me, it just seems there's so many different things that we need to understand, and you could ask and you could do. And, it's complex, particularly once you start getting into randomized trials, contribution of components, all sorts of other things like that. Do you think that there's enough patients in this situation, palpable stage 3? Maybe not in your practice or in the US or in the world, so kind of really get the kind of traction we need on these questions. The reason I say that partly is because in the old days, I guess we used to see a lot of palpable stage 3, and it just feels a little bit to me like we're seeing less now than we used to. So yeah, I'd be interested in your take on that.
It's a good question. I mean, we could ask our surgical colleagues. I think this is still such a common problem for them. These patients will often present, from a general practitioner's office to a surgical office, or from a derm, office where the melanoma is being detected, and then they realize, oh, there's also lymph nodes. I don't know. My instinct is to say yes to that, maybe without more of an explanation. But yes, I think there are these patients out there. I mean, I know in the US we have nearly 100,000 cases diagnosed every year, if not right there at 100,000 or more. And I think that means there's thousands of these stage 3s, and palpable bulky. Yeah, I think they're there. I think there's plenty to ask and answer all these questions.
Yeah, okay. Well, I mean, I think that's an important point, and I guess that also speaks to the importance of collaborative research in this space. So do we have any other take-homes, do you think, from this paper? Have we got everything?
Yeah, I think there's might be one other thing. When they did the correlatives on this, they're talking here about some cytoph that they did, mass cytometry that they did, looking at LAG3 and PD-1 levels. So LAG3 and PD1, PDL1, excuse me. Well, they looked at PD1, so that means they looked at T cells. But I guess the point is, we've been, I guess, certain feels like the wrong word. We've decided in melanoma that PDL1 expression is we know it's inducible. We know it's a dynamic marker. We don't use it really to say go, no go. It might be part of an algorithm once you've decided to treat somebody or decided that there are options for them. So you might use it then as a nuance when deciding between options. So there's no approvals outside of Europe that really should dictate that. Here, LAG3 and PD1 didn't correlate with pathologic response, and perhaps that's something for us to remember. These are preoperative tumor samples. They then get exposed. LAG3 and PD1 preoperative, which is where we're testing it in every one of these trials. It's in a pre-interventional state, is really not helpful in a melanoma patient, perhaps unless, sort of like if you're interferon gamma high at the beginning, if you're PD-L1 positive at the beginning, if you're LAG3 at the beginning, it narrows us down to where you're likely to have benefit, but it doesn't omit options. It just maybe clarifies options. The inverse is not true. A LAG3 negative, a PD-L1 negative, you have no idea what will happen to the expression of those markers after intervention. So I think you only really, I guess I'm not clarifying anything, am I? The comment that I'm trying to make is that they also saw that pre-treatment expression really didn't mean anything. And I suspect if we really drill down in all of these, it's where you can say there's a positive population where you can start to feel comfortable that your intervention will likely have benefit. It's when they're negative that you can't necessarily obviate the benefit that would happen with therapy.
Yeah, I mean, I think that's a massively important point as well, and we could probably spend a lot of time talking about it. You know, we have these thresholds. If you look across cancer, you know, and then there's regulatory considerations, we get reimbursement considerations, and so on and so forth. I'm always interested in the ones that are below the threshold. You know, what does that actually look like? And then this comes back to test characteristics and everything else, I suppose. But it's a great point. So maybe we should wrap up there. So a single dose of neoadjuvant PD-1 blockade predicts clinical outcomes in resectable melanoma. Really nice paper, Nature Medicine 2019, Huang et al. And actually, maybe the nice thing, or one of the nice things for me, is I think it's great when you can have a small series of patients and do this really in-depth correlative analysis. And actually, it really helps us understand what's going on. So congratulations, I think, to the authors. Thank you very much.
Thank you. Hi, everyone. A quick fact check for this episode. It's not really even about the episode. It's about the quickfire. James asks me if I make my bed, and I reference a commencement speech, and I said it was given by General McChrystal. Totally wrong. This was Admiral McRaven, who gave a commencement speech in 2014 at the University of Texas at Austin. Happens to be my alma mater. And Admiral McRaven goes on to talk about his life as a Navy SEAL and lessons learned. And he talks about making his bed. I mentioned that I make my bed not for the reasons in this speech, but I do think it's a fantastic commencement speech. So I would encourage anybody who hasn't listened to it to maybe go listen to it, find it on YouTube and listen to it, or read a transcript of it. I'll just read a little bit about the making your bed part. He talks about 10 lessons learned from basic SEAL training. And he said, every morning in basic SEAL training, my instructors, who at the time were all Vietnam veterans, would show up in my barracks room, and the first thing they would do is inspect your bed. If you did it right, the corners would be square, the covers pulled tight, the pillow centered just under the headboard, and the extra blanket folded neatly at the foot of the rack. That's Navy talk for bed. It was a simple task, mundane at best, but every morning we were required to make our bed to perfection. It seemed a little ridiculous at the time, particularly in light of the fact that we were aspiring to be real warriors, tough, battle-hardened SEALs, but the wisdom of this simple act has been proven to me many times over. If you make your bed every morning, you will have accomplished the first task of the day. It will give you a small sense of pride, and it will encourage you to do another task and another and another. By the end of the day, that one task completed will have turned into many tasks completed. Making your bed will also reinforce the fact that little things in life matter. If you can't do the little things right, you will never do the big things right. And if by chance you have a miserable day, you will come home to a bed that is made, that you made, and a made bed gives you encouragement that tomorrow will be better. If you want to change the world, start off by making your bed. I thought that was a nice excerpt. So that's really the only fact from this episode that we had. That's it.